Good afternoon, and thank you for attending this month's OCHIN Grand Rounds. Today, we are kicking off our 5th season with Rebecca Levenson of Futures Without Violence, presenting on Rethinking IPV Screening in the Context of Health Equity. Rebecca Levenson is a consultant with Futures Without Violence. As a nationally recognized researcher, educator, advocate, speaker, she has also worked extensively in the areas of IPV, primary care, adolescent, reproductive, and perinatal health within federal and state programs, community clinics, FQHCs, and home visitation programs for the past 20 years. She is an advocate of the potential to move beyond trauma-informed to healing-centered care. She is the architect of the Futures Evidence-Based Intervention CUES, which stands for Confidentiality, Universal Education/Empowerment, and Safer Planning/Supports. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions and comments through the chat box. This presentation will last approximately 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Rebecca Levenson for Rethinking IPV Screening in the Context of Health Equity, the Power of CUES, an evidence-based intervention that promotes healing and safety. And we will unshare our screen, and Rebecca, the floor is yours.
Thank you, William. I really appreciate you, and I'm hoping my share is working. Are you able to see my screen?
Yes.
Okay, and you are able to see my notes though. There, is that fixed?
Perfect.
Okay, wonderful. Well, welcome everyone. For those of you who aren't familiar with Futures Without Violence, we are the U.S. Department of Health and Human Services National Resource Center on health and domestic violence for the whole country. So what we create is to help you do your work and to help you think a little bit about strategies, and we develop tools and sorry, I'm just going to be COVID honest with everyone. I had to leave my house to do the webinar today because I have 3 kids home and everybody's on Zoom. And then I went to a friend's house and she's being helpful by not realizing I'm on a webinar right now and bringing me a glass of water. So please forgive that little distraction and interruption. In any case, what we do at Futures is we listen to you and we look at the latest research. We listen to survivors of domestic violence. We work with advocates really to kind of bring the best thinking to the field to support your work, helping survivors. And one of the things that I can't pretend, especially in this moment, I live in Berkeley, California, and for those of you who have been paying attention to national news, because I know a lot has been going on in Portland, you may know that a lot of California is on fire right now, and COVID is happening, and a whole lot of other things are happening. And so I want to better understand just how folks are on the call and give you just a second to type into the chat box how you're feeling today. So if you wouldn't mind, typing in the chat box, and I am hoping to be able to pull up the chat, which I don't seem to be. Hey, William?
Yes.
Are you able to see the chat?
I am. Would you like me to read some of the responses?
I would. Thank you so much.
All right. We have Ned Mossman saying anxious. Megan Hoops says stressed. Carla Dardius says, I'm feeling disoriented. Rachel Gold says, sort of keeping it together, ... sort of. Gil says anxious. Elizabeth says interested. Alan says anxious. Rose says exhausted. Anna says exhausted. Jenny says hanging in there. And Crystal says a little overwhelmed.
Yeah. So thank you for that, because I really think that how each of you are feeling, and there's a variety of things. Sometimes I also hear I'm feeling grateful, right? We're sitting with so much pain and suffering right now. Sometimes I hear that, but certainly anxiety, feeling burnt out, all of those things are folks that people are experiencing. And I just want to acknowledge that the folks on the phone may be feeling that too. And I think You know, I was so excited to do grand rounds for you all because I care so much about science. I care so much about health. I care so much about health equity. And, you know, Amy Acton, for those of you who haven't been following what happened in Ohio, is one of my total heroes. And you may know that at the beginning of COVID, she was making daily appearances, and she was the warmest, most compassionate doctor person imaginable. And I think what I loved about what she was doing is she was making the work around COVID and keeping yourself safe and wearing a mask absolutely part and parcel of who she was in the world, right? So she would tell a personal story. So I, you, us, we together do no harm is something I so appreciate. And again, for those of you who were following Amy's experience, as a result of her dedication as a public health servant and director, she experienced immeasurable pain and suffering at the hands of some of her Iowans, local folks who came to her door, who were anti-Semitic, who were anti-science, and she ended up leaving her position. So in the middle of all of this, for all of you who do this important work on the front lines and the providers and the researchers who are connected on this phone call, I just want to acknowledge that there is a personal level, I think, to COVID for those who are working in the front line in healthcare that I just really want to acknowledge and thank you. So I'm going to shift a little bit here. What are we going to talk about? We're going to be talking today a little bit about evolving practices around intimate partner violence and really thinking about that in the virtual context. I understand some of you are still seeing patients face-to-face. Some of you are completely virtual, so I'm going to try to hold some space around both of those ways of practicing medicine. You are going to learn about cues, and you're going to learn some strategies about safer planning. And just as a quick recap, right, so we know that intimate partner violence is about power and control, and it may or may not include any physical or sexual violence. It could be connected to mental health. It could be connected to economic power and control, all kinds of things. I think also many of you know this, but it's worth reminding ourselves that 1 in 3 women will experience intimate partner violence in her lifetime. 18 to 24-year-olds tend to have the highest rates of violence. And certainly we know that while intimate partner violence cuts across all race, class, sexual orientation, gender identity, some groups are more at risk. So we know Black, Indigenous, and other people of color have higher rates of intimate partner violence, and then transgender, non-binary, and gender non-conforming folks also have very high rates. We also know that under COVID, domestic violence, along with child abuse, is on the rise. So I think to make this relevant, and I understand that in addition to some staff from OCHIN, there are also maybe some folks visiting from Planned Parenthood on the webinar today, which is a place that's very near and dear to my heart. I was a director for Planned Parenthood for many years before coming to Futures Without Violence. And I think that to help sort of paint the picture of intimate partner violence and how it directly affects each of you doing work in healthcare, I think it's helpful to think about how it affects within broad categories: primary care, behavioral health, adolescent health, perinatal health, reproductive health, and sexual health, exactly how you might think it would show up. So we're thinking really beyond any kind of injury to things like chronic health issues, reoccurring issues, medication adherence. And if you wouldn't mind just typing in the chat box, and I'm going to see if I can again try to get in myself. But William, if I can't, I'm hoping you will be my eyes.
Sure.
Folks can think of examples. That would be great.
We have one from Dana that says, repeat unwanted pregnancies.
Absolutely. And I think, and forgive me for those of you who are sharing your brilliant insights in the chat. I think for just matters of time, I'm going to kind of move forward. You know, essentially what's worth noting here is that I can pretty much look at any chronic health issue and tell you it's going to be exacerbated by intimate partner violence. And I think also worth noting is that we have more and more data to show that traumatic brain injury is absolutely connected. So if you've got a patient that's showing up with headaches or you're worried about migraines, one of the things that I want you all to be thinking about is whether or not your patient maybe is experiencing those headaches as a result of someone whacking their head against a wall or strangling them. For primary care, I want you to think about for asthma. If you've got a client who's showing up in your emergency room department with out of control asthma, and perhaps there's a pattern of this, one of the questions I want you to be thinking about is her partner, as part of power and control, keeping inhalers away from her, which is very much part of how we've seen power and control show up around the issue of asthma. Moving forward, no surprise, we see high rates of issues in terms of behavioral health for folks who are experiencing intimate partner violence. No surprise that they sleep more, that they use drugs and alcohol to manage the pain. There's depression, anxiety, etc. And I think, again, this is, I think, a very helpful survey that was done on the National Domestic Violence Hotline. And it shows how power and control shows up in other kinds of ways. So if you've got a client who is working on sobriety or working on their drug addiction, it's worth noting how power and control might show up there, right? So hotline callers were pressured or forced to use alcohol or drugs by their abusive partner. Almost 25% were afraid to call the police. 60% tried to prevent or discourage them from getting help. These are their partners. And 37% threatened to report alcohol or drug use to someone in authority. And I think, again, these are ways in which we're not thinking about how sobriety is undermined, but I think it's very much worth keeping that in our picture. Somebody mentioned earlier about intimate partner violence being connected to unintended pregnancies and poor birth outcomes, sexually transmitted infections, including HIV. And then for our teens, I think that this is an interesting study in that what we're seeing here is that teens who are experiencing power and control over text or over social media, we know that when they're being put down, when they're being controlled, when they have a tracker on their phone that their abusive partner is using, we also know that that comes alongside higher risks for physical violence, right? So 52% say that they were also physically abused in addition to experiencing digital power and control, and 33% say that they were sexually coerced. So we know that this is happening. So I'm so sorry about that, everyone. But the question I was asking you to consider is how many of you have or know someone who has ever left something out of a medical history or intentionally misreported information to their healthcare provider? And I wanted you to share in the chat why. Why don't people tell us their stories? Or why don't you tell your personal story when asked? Okay. A judgment, embarrassed, shame, fear of judgment, lack of time. Nice. I mean, I think it's all of those things and definitely more. You know, you mentioned some of these, shame and judgment. I think in this climate, fear of system involvement and police involvement. So I'm not going to tell you about what's happening to me if I don't know what's going to happen when I tell you. I think there's real fears, especially around intimate partner violence. And if there's children, fear about system involvement there, child welfare involvement. Lack of awareness about your rights. I think there's lack of knowledge about US laws, I think is another reason. So if you're undocumented, the biggest thing you're worried about is deportation. So these are all things that play into why we can't tell our stories. And I actually think that that's a health equity issue, right? So especially if you think about the most marginalized among us, I think it makes it even harder because of all the system issues, et cetera, for folks to tell their stories. And the way that we've set up our system around intimate partner violence is incredibly complicated. I also think it's worth looking at some of the data about screening for domestic violence. Now, this is data from home visitation, but I think it really lends itself to a broader conversation about what works and us to ask ourselves in a bigger picture, what are we doing that potentially causes unintended harm, right? So what we know from Susan Jack, the researcher who did this for the Nurse Family Partnership, is that the use of structured tools, screening tools for intimate partner violence, does not promote disclosure or in-depth exploration of women's experiences of abuse. Women are more likely to discuss experiences of violence when the nurses had real conversations with them, right, about what was going on in their lives. And I think the earlier statistics I shared with you are really relevant here. So if you all think about what percentage of your population currently says yes to questions of domestic violence, it's going to be incredibly small relative to 1 in 3 women, right, experiencing this. So for my Planned Parenthood friends or my friends who are working in perinatal health, chances are your numbers look in the 3 to 4%, maybe if you're in a system that's doing a lot around these issues. Maybe a little bit more, but certainly nowhere around 1 in 3. So that's the other piece of this. The way that we currently structure our work leaves people who may need us the most unable to seek additional support and services because of how our system is set up. And there's a little bit more research here that I think is worth talking about. In mandatory reporting were not an issue, she'd tell the nurse everything about the abuse. I say no when my home visitor asks about abuse because that's how you play the game. People are afraid of social services. That's my biggest fear. And I think that listening to the voices of survivors is really important to understanding how we should be rethinking structuring care in this environment. And you know, my friend Liz Miller and I talk a lot about this. What if we challenge the limits of disclosure-driven practice? Okay, and what I mean by that is we create these checklists of yes/no questions and we weight them evenly, right? We ask questions about, is there a history of high blood pressure in your family? Is there a history of domestic violence? Is there a history of this, that, or the other thing? And I think if you really stop for a second and think about, well, we really function as a gatekeeper for information and the way that our system is set up. In order for me to give you information about where to get support and services, you have to tell me you have a problem. And we think from a health equity perspective that that is a problem. So the universal education, I think, is part of this answer. And so you see here an example of a little safety card that we've been using for our CUES intervention. And this is a card that's targeted obviously at moms. We have many, many other cards that target other populations, youth, LGBTQ folks, et cetera. But I wanted to give you an example of one of these little cards. And they are they're the size of a business card. They're multi-panel fold out. And they were really created to provide supports to providers around having conversations about healthy and safe relationships and ones that aren't, and making sure that everybody gets key information before they leave. There's also an empowerment element too. So here you can see an example of what's inside the card, right? How is it going? All moms deserve healthy relationships. So it talks about these elements, and it again provides the provider ways to have conversations about this, because we know that's what women actually want. And in addition, how do we get people to feel like the provider values them and they see that they are someone who has something to contribute to the outside world? So this strategy around altruism and helping others is a key element of this. So we have a panel on the card that talks about helping another mom. Everyone feels helpless at times, like nothing they do is right. So how connecting to people who might need it is really important for the patient. So it's not just something that is for the patient if they need it, it's also something to help friends and family. So the overview of CUES, if we were doing this in real time in a face-to-face clinical setting or in a home visitation setting, we would see the patient alone, we would talk about the limits of confidentiality, and then this is a very, very simple intervention. I've started giving 2 of these cards out to all my patients, and you would hand them 2 in case it's ever an issue for you, because relationships can change, and also so you have the info so you can help a friend or a family member if it's an issue for them. You open up the card. It talks about healthy and safe relationships, ones that aren't, and how they can affect your health and pregnancy. It connects things you might not otherwise see, like how substance abuse or depression can be connected to hard relationships. And on the back, there's a 24/7 text and hotlines that have folks who really understand complicated relationships. And you can talk to me about any health issues or questions you have. And, you know, as I mentioned, I gave you an example of one of many cards that have been developed in concert with folks in all different kinds of settings. So there's adolescent cards, behavioral health cards, cards that are focused on HIV, pediatrics, primary care, reproductive health, perinatal health, et cetera, many, many, many. And I think one of the things that we've been learning along the way is as many folks who do research know, sometimes you learn things along the way that really shapes the intervention. And the way that we realized giving 2 of the cards was really important was years ago now, when we were working with a medical assistant who had given that little spiel and had 1 card in her hand and said, you know, hey, we're giving this to all of our clients. And the client says, well, thanks, but I don't need it. I'm not in a relationship right now. And it was that medical assistant who turned her around and said, oh my gosh, what do I do now? And what she ended up doing was in that moment with that patient saying, well, I'm glad to know that you're not being hurt by anybody right now, but maybe you want to take a couple of these and you could give them to a friend or somebody who needs it. And the client literally stopped and asked for 8 of those cards. And that was the moment where things really shifted for us. So altruism is a really important part of this. So the essence of cues is really healing-centered engagement. It builds relationships. It improves access to advocacy. It shares power between the patient and the client and the provider. Some of the research behind cues face-to-face, we know that it makes a difference for providers. The card made me feel empowered because you can really help somebody that might have been afraid to say anything or didn't know how to approach the topic. This is a door for them to open so they can feel more relaxed about talking about it. Patients told us, getting the card actually makes me feel like I have a lot of power to help somebody. So what we realized in COVID is, given that most clinics were going to virtual visits, that we needed to create something that was going to make a difference to them and figure out a way to help providers with these over-the-phone situations. So we really thought about how can we take this physical card and turn it into something meaningful in COVID. So we think virtual cues is a lifeline. And really, again, some of you are already doing things like this and have protocols like this, but we know scripts can be helpful. So here's what we suggested that others might think about doing when they're getting ready to set up appointments over the phone. Hi, nice to virtually meet you. My name is, I'm going to be helping you with your appointment today. Before we get started, we always ask if you're in a confidential setting, meaning, can anyone overhear our conversation? If so, might you be able to talk somewhere private so we can speak more freely? And of course, because what we're trying to do is do no harm, and we recognize in COVID, really abusive controlling partners are going to be potentially listening and overhearing all conversations that happen. So we really want to think about how to improve safety and privacy for that client. You know, other strategies, can you take yourself out for a walk while we talk? Can they go sit in their cars, etc.? Then here's ideas about, you know, if there's kids in the room, giving them headsets or putting them in front of screens so that you can talk privately there or more privately in that space. We have been thinking a lot about, so we know in some cases it might be a medical assistant who could do cues. In other cases, it's going to be a clinician who wants to do cues. We know that it can work with different kinds of providers. We've had, you know, nurses do this, doctors do this, PAs do this, health educators do this, social workers do this. So you can see that this is, the idea here is to tailor it for your setting. But in this case, I'm talking about someone over the phone setting up an appointment. So tell me a little bit about how we can help you today. Great, here's how this works. I'm going to email the doctor. When they're free, they're going to call you with their concerns. And here's the part where we're going to shift into virtual cues. So I know with COVID, it's a hard time for all of us. Stress can be overwhelming. We're all worried about how we're going to feed our families, pay bills. Everyone's on top of each other in the house, or maybe feeling lonely if they live alone. How's it been for you? And just like at the outset of our call today, I asked you, how are you? Where are you? You know, it's that little moment that makes someone feel more connected and less alone. So we really just want to help whomever is on the phone with them mirror back what they hear. So that sounds hard or complicated, or I'm glad your family's doing okay. We're just going to mirror back what the client says. And this is actually being done at One Community Health in your own home state. They're one of the sites that is doing virtual cues. So one of the things at One Community Health we've been doing is really listening to our patients. And many have been telling us that they are feeling lonely, scared, and sad. We've been talking with all of our patients about strategies that can help your health and COVID. It's so important to connect to others. So virtual cues is really these little sweet nuggets of connection and scripts that can help reduce isolation and make sure that people have key information. We decided that COVID was an opportunity to get crisis text information out to everyone without focusing on domestic violence, and that might be the best and safest strategy for you to use with your patients. So quickly, here's the script. To help folks feel less alone, we've been sharing quick texts with simple ideas about supports to help if you're feeling sad or overwhelmed by COVID. And you can also pass on to someone you care about too. Like saying things aloud that are positive, especially on hard days, saying things like, together we're going to get through this, or saying how much you love or care about others can help reduce isolation. The other thing I'm sharing with all of our patients is an online support resource. Because we're so isolated, it's important to know where you can get free confidential help from everything from anxiety to depression to relationship stress issues. Or if you're worried about COVID-19, you can text home to 741-741 to connect with a crisis counselor. And here's an example of the text that you can send as you're on the phone with them, or you can put this in your chat if you're using an EHR. I mean, I know each of you are sort of, some of your patients have the ability to Zoom and have smartphones, others do not, they have flip phones. But we wanted to create a package of a sort of pre-assembled text for you to send. And so you can see how we're using COVID here as a way to talk about stress and using a general crisis text line to make sure that they at least have some place to go to get supports. And then, you know, here's an example of a universal script for intimate partner violence if you feel like the patient is in a place where they are safer, right? COVID-19 has made things harder for everyone while we're all isolated, stuck at home, maybe worried about jobs or housing. With all that's going on, we may be feeling stressed, we may hurt each other or our kids, yell, make someone feel ashamed, maybe we stop listening. The question is, what can help? And where can we go to find out how to get support? So there's a confidential national domestic violence hotline number. So you can see how in an EHR, you could populate it with these series of scripts to help providers or medical assistants or nurses have these conversations. And here's the example of the universal text that would go out around domestic violence. And of course, we're framing this as something that we're sending to all of our patients to normalize it, but we're also suggesting that they probably know people who are struggling in COVID as well, who need that help and support. So what should the follow-up be about the domestic violence hotline? You can offer over the phone that they can jot it down, that you can text the number to them if they'd like. Maybe the client says, I don't need it, things are fine, great. So you can say, I'm glad to hear that. If anything should change, we're here for you. We always have the numbers handy if you know someone who needs them. If they do want to write it down, they want you to send the number to them in a chat or in a text, thanks so much. And you know, if something like this were to ever be an issue for you, we're here for you. Please know we care about you or you and your children. I think that finding the words, if there is a disclosure to intimate partner violence, can be hard. I think folks can be flooded. Maybe they've had their own experiences with domestic violence themselves. Maybe it's hard because you didn't expect to hear that from the client that you thought you knew really well, and this is new information that you're receiving from someone. So I think having scripts can really make a difference, right? So remember, you don't have to be in crisis to get support. A lot of people struggle in their relationships and it hurts. Because remember, if we go back to the beginning of this webinar, we talked about how domestic violence or intimate partner violence is really about power and control. It may have nothing to do with any physical violence, but it may, at the emotional toll that it can take if someone's being told they're worthless, et cetera, absolutely affects your health and well-being too. So really suggesting that advocacy is there for them and that it can be a really big help matters. You want to say, thank you for sharing this with me. You deserve to be treated with respect. You're not alone. I'm here to support you. And if you follow my arrows down, you can see in the under the second green arrow, there are confidential services I can help connect you to, or make a 3-way call and stay on the line with you, whatever you want. So how do you do that? So what do you say when you call the domestic violence advocacy line? And we give you a script for that too. Hi, my name is Shannon. I work at the health clinic and I have a client with me on the line who's in a complicated relationship and asked me to help connect them to you. So we worked with DV advocates and the National Domestic Violence Hotline to develop sort of these disclosure scripts for you so that you would have more supports in COVID. So, I mean, it's just as a sort of an overview then, again, virtual queues is a lifeline. What we do when we go down this road is, I think we address the issue of equity. We make sure that everybody has key information. I also think that there's this other crucial thing that happens, which is just this in and of itself makes folks feel more connected and like their center really cares. And of course, we know that sharing vital information about hotlines and services can, in fact, help lives. So I guess my question to you all in the chat box is, what are your thoughts about virtual queues as a strategy to help clients? And I'm looking at my chat. So any thoughts about learning about virtual queues? You think this is something that's useful, that could be helpful? Are you doing something like this now? For my friends who do EHR, I think you can probably see why we were excited about sharing this with OCHIN, just thinking about Epic and having some more tools for providers and queues. I like them. It makes me feel less helpless. It sounds like a very powerful strategy. Thank you. Others? Okay. Well, thank you for that. And I have a couple more I want to share with you. One of the strategies, and this was our work with One Community Health in terms of safety in COVID, recognizing again that an abusive controlling partner may be trying to control everything, all conversations and information. So we were strategizing about one more way to help improve safety or a harm reduction strategy for the folks that you're working with. So the reason I'm sharing this with you today is because we all know someone in a complicated relationship, but maybe don't know what help is available. So instead of sending the hotline number, just like with the crisis text line number at One Community Health, this was their strategy. So I wanted to share that with you. I send every one of our patients a link to our One Community Health resource page. And on it is everything from information about food banks to housing and ideas about how to get help on complicated relationships. The information about supports for relationships includes domestic violence hotlines and info about local advocacy programs. I could also give you any of those numbers right now if that would be helpful. So what they did was they created a little bit of a layer using that info sheet and the One Community Health sort of resource list as a place to park more resources on domestic violence, so that if the abusive partner is walking by that Zoom screen and they're looking at the one community health sheet, it's less specific to domestic violence. And that was also true with the crisis hotline or crisis text line, because we know, because we called that line and talked, we texted that line, we know that they're able to refer to the hotline. And one of the reasons why the strategy of a three-way call is really important is if, again, you have a controlling partner, they're going to be looking at your call log or your text log. So if you're doing a three-way call, the only number they're going to see is the health clinic number. They're not going to see the DV hotline number if you're the ones that initiate that three-way call. And that could be an incredibly important opportunity for safety planning with the folks that you serve, as might this resource list shaped in this way. I also just really want to encourage you, if you don't have a great relationship, and you should be so proud in Oregon, because the Oregon Coalition is one of the very best one of the best coalitions in the whole country. There's so much wisdom and heart and a vision about equity, a vision about racial justice as part of social justice, and reducing or eliminating violence has to be wedded to our anti-racism work. I just really love Oregon. And I just want to encourage you, because each and every domestic violence advocacy program is a little bit different. It offers different services. And certainly in COVID, it's going to look really different. So I would just really encourage you on this call to think about calling up your local program, finding out what's happening, and then populating your EHR with updated information when it's appropriate. And just as a recap for those of you who don't know much about DV services, they can help you with doing safer planning on the phone. You can call them up and get ideas, and you can problem solve with them. That's their job. They would be happy to do that for you. So if you have a client who doesn't want to talk to a DV advocate, but they want to talk to you more about what's happening in their lives, that DV advocate can help you do safety planning, and then you can be the conduit that gives it back to the client. So there's just a lot of opportunities there. They do systems advocacy, including for undocumented folks. Especially in COVID, some of the shelters may be shut down, but they certainly are offering hotel vouchers, et cetera. I also, just in terms of other things to think about here, for your EHR, there definitely are more than just the National Domestic Violence Hotline. There are some community-specific hotlines. So there's a trans lifeline that you might want to populate. So if you on your EHR know that one of your clients is trans, maybe you can set it up so that the hotline number that pops up really is the most relevant one for the population that you're working with. Same thing is true if you're working with Native American Indians, that there's a specific hotline for them that then rolls over to the general National Domestic Violence Hotline. Also, there's the national trafficking number here as well. So you could think about ways in which these other numbers might be helpful to your client population. And then lastly, I always want to leave folks with more to think about, more to chew on. I was asked by the Oregon Coalition Against Domestic Violence to help them think about what they wanted to say to the Oregon Health Authority around integrating social determinants of health into the EHR. And I wanted to share this with you because I know some of you are researchers and thinking deeply about these issues. I want folks to consider lessons learned from domestic violence. I want you to consider the limits of disclosure-driven practice and why people can't tell us their stories all the time, especially parent people, especially people with little kids. I want you to think about what the literature already tells us, that if you're poor, the likelihood that you have 3 or more ACEs is so high. So that rather than continuing to sort of measure numbers, we can use other proxies to think about funneling folks into getting more social support programming. I want us to think outside the medical model about screen, diagnose, and refer when it comes to social determinants of health and intimate partner violence, and really think about shifting our lens to the core of advocacy. And then lastly, in your state, because again, Oregon is an innovator. You are a state that is thinking deeply about who is a community health worker. And one of the things that in my dream is really having domestic violence advocates fall under that role so that they can be an important and key part of working with families in your settings. And we, of course, would want them to be able to keep their confidential status so that they can really help people who don't want intimate partner violence to necessarily be a part of their medical history. But I think that there's some really innovative ways to think about this role moving forward. So I'm gonna just ask us all to do just one little quick mindful moment. Wrap your arms around yourself, your left hand's over your right, and rub your arm. Give yourself a squeeze, switch arms. Do the same thing. And rub your arm, and we're gonna stretch your hands in the air and wiggle your fingers and shake your hands and come back to center. And this is, again, from one of our qualitative studies. We've done both quantitative and qualitative on the cues intervention, but this is an interview that will stay with me forever. So this is what this young woman said. There will be times where I just read the card and remind myself not to go back. I'll use it so I don't step back. I'll pick up on the subtle stuff because they'll trigger me. I remember what it was like. I remember feeling like this. I remember going through this, and I'm not going to do it again. For me, it just helped me stay away from what I got out of. I carry it with me, actually. I carry it in my wallet. It's with me every day.
All right. Thank you, Dana, and thank you, Rebecca, for that insightful presentation. And thank you to everyone who attended today's session. Be sure to follow Futures Without Violence on Twitter at @withoutviolence and check out their website at futureswithoutviolence.org. And follow OCHIN on Twitter over at OCHININC and over on LinkedIn. In addition, be sure to head over to OCHIN.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And be sure to stay tuned for next month's OCHIN Grand Rounds as we welcome Dr. Erica Cottrell of OCHIN and Oregon Health and Science University's Department of Family Medicine as she presents on highlighting patient voices through the Health Experiences Research Network and the DIPEX project. Invitations will go out 2 weeks prior to the event. So, from all of us at OCHIN and from Rebecca Levenson to all of you out there, have a great day and please stay healthy out there.
Thank you. Thank you, William, for all of your support for this webinar today. Thank you so much.
Thank you.